2020 awardee. Go ahead, John.
Good morning, Lisa, and thank you very much. I share your enthusiasm for the meeting. I know how much work you and your team have done to put the Paving Your Way conference together this year, overcoming all of the hurdles. There's good news and bad news on the virtual, right? We get to take it in our own home, and now we, with the weather that's going to be so nice today and tomorrow, we won't be in the atrium of the hotel with the sun beating down on us all day long. So
True.
some advantages. But good morning, everyone. As Lisa said, it is really my great honor to posthumously present the 2020 Tony Windsor Award to our good friend Oscar Arocha. For those of you, I'm sure many of you on the phone or on the video today knew Oscar and was a friend. And if you knew Oscar, you were a friend to Oscar. He was a passionate language access advocate, a mentor to many of us, myself included, a colleague, and most importantly, a treasured friend to many of the folks that are on the call today. As I said, I was very, very fortunate to have the opportunity to meet and get to know and work with Oscar for several years. When he had left Language Line years ago when I met him as the new partner for Oscar when he was over at EMK. And his guidance, his willingness to work with you, to coach and work on solutions was just fabulous. And he taught me one of the most important lessons, and we're never too old to learn new tricks, as old as I am. He taught, he's one of the most important things, and all of you interpreters on the phone can appreciate this and take this to heart, is one of the most important things in communications is listening. And Oscar, if you knew Oscar, one of the best things he does is able to listen and understand. And as Lisa mentioned, in today's culture, it's so important that we listen and understand and appreciate all. And really, that's what Oscar was about. The Tony Windsor Award, one of the tenets of the Tony Windsor Award is to improve language access to all persons. And if there's anything legacy that Oscar has left, is from his time at way back when, those many years ago at BMC, and all the folks he has influenced and mentored over the years at BMC, through his last assignment where he was working to support the folks at EMK, but also keeping his hand and working with the team at UMass day to day and helping the patients. Language access, as we'll find today, doesn't work without champions like Oscar. You need to be a fierce ally, not only to represent your patients, but to get an organization or outside organizations to understand and enhance and embrace the importance of language access. And when an organization is lucky enough to have someone like Oscar, it can literally change the lives of thousands and thousands of people over time. And I think anybody who has worked with and met Oscar or had the opportunity to sit around while he's playing his drums knew that about Oscar. Thanks to his advocacy to improve language access and to professionalize the field of medical interpretation that we all appreciate and try to improve every day, his legacy will live on in the future. I know that I speak for everybody on the call today and those who couldn't make the call, that he is greatly missed by his friends and colleagues. And I am, again, greatly honored that I was able to be selected to present the 2020 Tony Windsor Award posthumously to Oscar Arocha. And Lisa, I thank you for that. And I think it's a tremendous achievement and a great selection. So thank you. And I hope everybody has a fantastic 2 days here at Paving the Way.
Certainly, and hopefully all of you will join us in the meet and greet at lunchtime today. You'll just have to click on that Zoom link. All right, with no further delay, I'd like to introduce my colleague, and I have the pleasure of introducing Dr. Lisa Colombo. Lisa currently serves as Executive Vice Chancellor of Commonwealth Medicine, which is the Consulting and Operations Division of UMass Medical School. Through its team of healthcare policy, finance, and clinical experts, Commonwealth Medicine helps make quality healthcare services available to our community's most vulnerable populations, which is why it is such a natural fit and why we are so pleased to have Commonwealth Medicine together with UMass Medical School, Mass AHEC, as the host of our Conference for Medical Interpreters. Previously, Lisa served as Senior Vice President and Chief Nursing Officer at UMass Memorial Medical Center. She has served as President of UMass Memorial Clinton Hospital and as both Corporate Vice President for Clinical Operations and Chief Nursing Officer at UMass Health Alliance Hospital in Leominster. Lisa has held senior level executive and nursing positions at Leahy Hospital and Medical Center, Milton Hospital, Beth Israel Deaconess Medical Center, New England Baptist Hospital, and the Visiting Nurse Association of Central Massachusetts. She also has experience as a private consultant in physician practice management. As a healthcare educator, Lisa has taught doctoral level courses in the UMass Medical School Graduate School of Nursing. She is a prolific author on healthcare and nursing and has served as a peer reviewer for the Journal of Healthcare Quality and the Journal of Advanced Nursing. Lisa earned her Bachelor of Science in Nursing at Worcester State University, a master's degree in health administration at Clark University, and a Doctor of Nursing practice at the Massachusetts General Hospital Institute of Health Professions. She is an extraordinarily experienced and distinguished healthcare executive and educator. I am pleased to have you join us and welcome Dr. Lisa Colombo.
Thank you so much, Lisa. When I hear all that, it makes me feel old. I've been very blessed in my career. I've been the Executive Vice Chancellor at Commonwealth Medicine now for almost 2 years, and it's probably been the most wonderful experience of my life, primarily because of the mission that we have, which is to serve those who are underserved and served by public assistance programs. I get my greatest joy from having the opportunity to connect directly with the work that all of you do to serve our healthcare community. Conferences like this bring healthcare professionals together to learn and to network and to celebrate all the good that you do every day. And so it's my great honor to address all of you who are attending this 15th annual Paving the Way to Healthcare Access Conference for Medical Interpreters. This is a unique circumstance and certainly a milestone for Commonwealth Medicine, as this is our first totally virtual conference, and Lisa certainly can attest to the challenges that that brings with it. I want to thank you for your continued engagement and for wanting to come together enough to do it virtually. I doubt that you'll be disappointed with your experience over the next 2 days at this conference, and I encourage you to be present and focus and get all that you can from the collegiality of all the folks on this call today. Despite the challenges of hosting a virtual conference, we have more than 315 registered attendees from 19 states and a total of 23 languages that are represented in our event. So let me begin by congratulating all of you. Your choice to take part in this conference speaks volumes about your commitment as a professional medical interpreter. And it speaks to how, during a global pandemic, the role of the medical interpreter, the training and skills that you bring, and the value that you add to every encounter is more important and more relevant than ever in the mission to improve access and quality of healthcare services. Before I continue, I do want to take a moment to recognize Lisa Morris for her exceptional work during the COVID-19 pandemic. Commonwealth Medicine has been very closely partnered with the state of Massachusetts in responding to the COVID-19 crisis. And early in the state's response, Lisa was called upon to assist the Massachusetts Department of Public Health to translate the Bowie Health application COVID-19 symptom checker It had been developed in English and needed to be translated into multiple other languages. And as you can imagine, the translations needed to be done in an incredibly short timeline. And Lisa brought her unique skills and expertise to help on this important project under very extraordinary circumstances. And of course, she got it done on time and with a high degree of quality. I was quite proud and very impressed with the way that she continues to show her professionalism in her craft. She's also provided translation service for the DPH COVID-19 text alert system, which covers the state of Massachusetts. And she did all of this in addition to her everyday job, which is working directly with the Center for Health Impact in Central Mass AHEC, providing translation services for all of the Massachusetts Medicaid publications. It's interesting to note that at UMass Medical School and Commonwealth Medicine, Lisa holds the title of Director of Cross-Cultural Initiatives. I think that's significant because it goes to the heart of how medical interpreters serve our healthcare system. That title is emblematic of the importance of the role. And yes, medical interpreters must possess a high degree of language fluency. And yes, medical interpreters must have a thorough understanding of complex diagnoses and treatment. And yes, medical interpreters must be able to read the moment so that they know when to stand in the background and when to step forward to assist. And yes, medical interpreters must also be familiar with the laws and regulations regarding privacy and reimbursement. They must know all of these things, and perhaps the most essential skill for a medical interpreter is to have the high degree of cultural knowledge and sensitivity which they bring to their work every single day. That particular combination of linguistic and legal expertise and the cultural knowledge and sensitivity, which is what enables the medical interpreter to reduce the risks associated with misunderstanding a diagnosis or treatment plan. That training, knowledge, and sensitivity remove emotional bias. It reduces the trauma and the anxiety of a situation for a patient. It helps build trust between the patient, their family, and their physicians or care team. It improves compliance with prescription and treatment plans and reduces the risk for more extended hospital stays and adverse outcomes. And all of that helps reduce the cost of healthcare and the risk of litigation. There's another skill that the medical interpreter must possess. In the post-COVID-19 world, where telehealth services will be far more prevalent, in fact, they may become the rule rather than the exception, medical interpreters will need a high degree of technical savvy to integrate and deliver their services in any setting seamlessly, whether it's a hospital, a doctor's office, the courts, or a conference. And of course, someone has to pay for interpreter services. At Commonwealth Medicine, our experts in health law and policy work closely with state agencies and community providers to develop and implement the right reimbursement tools so that their specific populations and organizations can benefit from the critical services that you deliver every day. But perhaps the most important message that I want to leave with you today is that what you do is critically important to the health and safety of patients, particularly to those who are among our nation's most vulnerable. Your work keeps people safe and it improves health outcomes. As a nurse, I've seen firsthand the value of your work. You are a valued and trusted member of the healthcare delivery team across this country. Your work helps others on the healthcare team to appreciate, to understand, and to celebrate the cultural differences among patients, providers, and families. In these unprecedented times, I implore you to double down and to stay focused on doing what you do best. And I want to thank you again for the great privilege of being here with you today and making the opening remarks. I recognize your commitment to your profession, and I honor and sincerely appreciate the devotion to serving others in your roles as medical interpreters. Now I actually have the great honor of introducing your keynote speaker, Elena Langdon. Elena is a partner and co-founder of Seven Sisters Interpreter Training and Consulting, which has locations in Western Massachusetts, Indianapolis, and Guatemala City. Elena is bicultural and a bilingual professional, American by birth and Brazilian by heart. She was educated in both countries and has been a full-time translator-interpreter since 2000. As a supervisor of interpreter and translation services at Bay State Medical Center, Elena managed a staff of more than 50 interpreters who produced over 4,000 pages of translations a year. In 2014, she established the ACOLA Language Services and Consulting to bring the faraway closer to home for clients by bridging cultural and linguistic differences. Elena holds a BA in Broadcast Journalism and a Master of Arts in Translation Studies. She is also a certified translator through the American Translators Association, a certified interpreter through the Certification Commission for Healthcare Interpreters, and a screened court interpreter through the Massachusetts Trial Court. And what's more, as if that wasn't enough, she is a seasoned triathlete, which is quite impressive, I might add, who applies her experience in preparation, mental toughness, and stamina and determination to her work as a medical interpreter. It is my honor to introduce to you Elena Langdon.
Thank you, Lisa.
Thank you so much for that wonderful introduction. It's an honor to be here. I'm going to go ahead and share my screen, and you can just confirm that I'm sharing the right screen. Okay, does that look good? Can you see the top of that? If I can just get a vocal confirmation, that would help.
Yes,
I can see it, Elena.
Great, thank you. Well, thank you so much. It's a real honor to be here today, and it was nice to hear that very long introduction based on so many different things that I've written. It was interesting to hear. So thank you for having me, and welcome to Paving the Way 2020. This is what we're going to talk about today. We're going to talk about the overall impact that COVID has had in very, very general terms, right? I'm just going to remind us all of what we probably very clearly know, and then talk about the impact on language access, and really from the perspective of interpreters, looking also a little bit about what facilities have been doing, and also I was able to bring in the patients who work with interpreters through the excellent work that researchers have done in this area. There's very little work being done on what patients expect and get from interpreters and from an interpreted encounter, but there is some, and I'm going to talk a little bit about that, about their perspective based on those researchers and what they've done, and talk a little bit about what has been working, what facilities have done to step up, what interpreters are feeling about it, what they've done, and then think about what are the next steps. How do we go forward with this in a life that is so changed. This is a quote that I like to show often, and I think it applies especially for today's situation. And it's from Viktor Frankl, who wrote Man's Search for Meaning, a wonderful book with a very, very positive and enriching take on what it means to go through incredible pain and yet get meaning from it, to get something out of something that's quite negative. He was a survivor of the Holocaust, and he also lost his entire family in the Holocaust, and yet he went on to live a full life, thrived, contributed much to his field of psychology, and in countless other ways as well. And I talk about this when I talk about mindfulness too, which is another favorite topic of mine, when we think about, because it connects so well with the idea of mindfulness, which is that when you have a stimulus, which can be negative or positive, right? You have the opportunity to respond to that. And it's your choice. Not that it's easy, it's a lot of work to have to see that choice, but we do have the choice in how we respond, and to do some work in ourselves so that on a regular basis, when we have stimulus that might not be, that is painful, it doesn't necessarily have to cause suffering. and then this idea also from Buddhism, that a difference between pain and suffering, and that a lot of our suffering we cause ourselves, but that pain is inevitable, but we don't necessarily have to suffer from that. And it's about seeing the opportunity, seeing what we can learn, you know, the old cliche of learning from our mistakes or learning from adversity. And I think it's really important in this moment to keep that in mind. And as Lisa and John and Lisa Colombo so aptly put it, we are living unprecedented times, and really a moment that none of us have, or very few of us have, witnessed before. And it's also a moment that we're all witnessing together, which I think in many ways, this is of course my opinion, but I think in many ways it's what brings us together. We are all able to see anyone else from that light, knowing that no matter who we see on the street, on Zoom, at the supermarket, behind our masks, that person is going through the same situation. Of course, the situation is going to be different for them. Their experience of it, their difficulties are going to be different than our own, but it is a shared experience. You know, unless you're living completely isolated in the woods and always have been and continue to not have any outside information coming to you, then this is something that's affecting you. And so I think that that unified experience, or that joint experience, can be a very positive moment. It's not divisive. It actually has the potential, and I think it is bringing us together. And I've noticed in the few interactions that I have with strangers or neighbors or people that I don't know very well, I feel that we're all being kinder and gentler, and going out of our way to wave and smile, again, behind our masks oftentimes. Perhaps it's the optimist in me, but to me, it really feels like that. I wanted to mention David Kessler because he wrote a book about grief, and he also is someone who had a lot of pain in his life, who lost a lot of people, who went through a lot of difficult experiences, and worked a lot with the author of the seminal book about the 5 stages of grief, and came up with the idea of a 6th phase of grief. So the 6th stage, rather. So after acceptance, the 6th stage of grief is meaning. And he was reading Viktor Frankl's work as he was thinking about this. Even though he had already had a lot of pain in his life and lost a lot of people, as he was working on this project, or had already kind of started thinking about it and wanting to do it, lost his adult son suddenly. And then really felt compelled to write a book about this. And he was on an excellent podcast. I'm a big podcast fan. And he was on, I think it's the top #1 podcast right now, which is called Unlocking Us by Brene Brown. And if you don't know her, she's doing really interesting work about being vulnerable and how there's power in being vulnerable. Daring Greatly is her one of her big books, and she's got this wonderful podcast, brand new for the pandemic, called Unlocking Us. And David Kessler was on it, and they were talking about grief, and they were talking about this idea of collective grief, and how a lot of people might not recognize this as something that we are going to grieve over, that we are grieving over, because perhaps a lot of us, or not perhaps, a lot of us have not yet lost anyone dear to us. A lot of us are fortunate and might be more isolated from the pain that's going on. Probably not many of you in this audience. Medical interpreters certainly are not isolated from it. But there are a number of people who are able to stay home and not work and not be so exposed to it and not have lost anyone and kind of feel like, well, why is this grief? And he really made a very interesting point, I thought, to this, which was that, you know, we're grieving because the world that we've been accustomed to is gone. And I want to play, I'm hoping it's going to work. I'm going to play, 10 seconds, 30 seconds here of what he said as part of that episode of Brene Brown's podcast. Okay, and the audio is not loading now. It loaded when we tested it, of course, but
okay, I'm going to test this to see if I can get this recording.
You should hear this audio. And it'll get louder.
That we've all been accustomed to is now gone. And we're collectively, just like you said, so many people are feeling heaviness. So many people are talking about, I woke up and cried. I went to bed and cried. And just like you, I'm like, it's grief. And yet there's a part of us that goes, grief, no one died yet. And we don't understand. When people say to me, what is grief? I'll say it's the death of something. It's the death of a loved one. It's the death of a marriage. It's called a divorce. It's the death of a relationship. It's called a breakup. A job loss is the loss of that work world you had. This is a collective loss of the world we all lived in before the pandemic. And we, like every other loss, didn't know what we had until it was gone. And so here we are, and just like you, we're all trying to find ways to virtually hold each other's hands. We're in this together. It is not going to be forever. It will end. There's not a dark night that stays, and yet we have to feel these feelings. We've got to feel the grief.
I think that's been the thread through every.
So I suppose I misrepresented when I said it was only 10 seconds, but I think it's a really powerful statement about grief and about this collective loss that I mentioned that we have. And it's up to us, I think, following what David Kessler has been doing to find meaning in that. Okay, so let's move on to what you probably came here for, which is talking about this impact on our field, talking about the impact on us as interpreters, as interpreter managers, as medical providers, as facilities, as patients, as limited English proficient patients, patients who work with interpreters or should be working with interpreters, but they don't have access yet, and of course, to all of our healthcare interpreters. And so when I started to look at this as an overall impact, I came across what I'm sure all of you are very familiar with, which is this idea that the disparities that existed already in healthcare, in health outcomes, have only been exacerbated by the pandemic. Right, so the populations that were suffering already in disparate numbers due to their socioeconomic status, due to their geographic location, due to their work status, or due to their ethnicity, are being adversely affected during COVID, which is one of the saddest things to see, really heart-wrenching. So we have seen an increase in hospitalization and death among Blacks and Latinos, and this has been documented in many, many different areas. New York, of course, being the epicenter of the pandemic and where the highest numbers come from in terms of people affected and deaths in this country, bore that out, confirmed that. More hospitalizations, which implies more serious reaction, right, to the virus, and much higher rates of death, right, higher than what the Blacks are in terms of the proportion, the percentage of the population. And the same thing for Latinos. We saw this in Louisiana as well, and other states. You know, and the numbers, if you want the numbers were for Blacks and Latinos respectively, 92 out of every 100,000 versus 45, 92 out of every 100,000 for hospitalizations, 74 for deaths versus 45 or 34 for whites. And I'm going too forward there, for whites and Asians. Why is this? Again, this is a brief overview about these disparities and what's going on with that, because it's certainly not, as far as most people talk about it, is certainly not a genetic thing. The biggest reason really are the socioeconomic factors. So one of the things that we see with the populations that are most affected by health disparities and by COVID-19 is that they live in densely populated areas. They also live in residential areas that are segregated, that are racially segregated, right? So there's a higher density of Blacks or Latinos living tightly together. We see a much higher rate of multi-generational families in these groups, right, among Latinos and Blacks. They tend to be further away from sources of nutritious food and from medical care. They are also overrepresented by a lot, as we all know, in prisons, jails, and detention centers. So the living conditions contribute a lot to the why of this. Also, in terms of work, there's a lot of differences. So 25% of employed Hispanic and Black workers are employed in service industry jobs, compared to 16% of non-Hispanic whites. So again, 25% of Hispanic and Black or African American are employed in service industry compared to 16%. And we all know the choices that one can make if one is not in a service industry. We have a lot more choices. If you're working on the front lines in services, you often don't have any choice but to go to work. Hispanic workers account for 17% of total employment, but constitute 53% of agricultural workers. So also a very big difference there. And Black or African Americans make up 12% of all employed workers, but account for 30% of licensed practical and licensed vocational nurses. Okay, so 30%. So the percentages are different in terms of how many of them are working in these fields that are also directly impacted by the pandemic. Then when I started to think more about the overall impact that it's had, and I think what I saw was this increased, sorry, my mouse is very happy this morning to move along when I don't want to. This increased dependence on technology. What does this mean, right? We are depending on technology more than ever for our communication. Okay, a lot of us were already doing this. Certainly the younger generation was already doing this a lot more than those of us who are older. But now it's pretty much the only thing we're doing. So internet access and literacy, internet illiteracy, right? So technology literacy, big gaps there. Okay, so we're seeing this as an overall impact as we move to Zoom, as we move to online forms of interaction and communication. We're going to see gaps in terms of how people can dialogue with that and how people can work with it. Not only just because do they even have access to it, but are they conversant with the technology? The same thing with phone access. It's hard for a lot of us to believe, but not everyone has access to a smartphone. And so this plays into communication as well. generational gaps, of course, right? Because communication works very differently. We're more or less comfortable with different types of communication depending on our generation, depending on what we are used to. I saw this hilarious video where a father he was testing his 2 teenage boys to see if they could use the rotary phone, and he gave them instructions, and they had no idea how to use it, right? The concept of, how do you dial the rotary? You have to have the phone picked up and hold it, while you hear the dial tone, and that's when you dial it. This is a process that's completely gone from their knowledge. And similarly, the way of communicating. Many of us don't like communicating via text. I have multiple friends that really, they just never text me back. I have to call them. And so this increased dependence on technology for communication during this time, we see this generational gap in terms of how people can access it and how they can interact with it. The same thing in terms of thinking about meaningful connection. Are we able to get meaningful connection through this kind of technology for communication? Again, this is all still in very general terms. And then social interactions, same thing. Is it meaningful? Are our social interactions through video calls or audio calls, text messaging, all the things that we still do have, thankfully, available to us? How meaningful are those connections? Probably a lot of you have been slowly going back and perhaps seeing friends staying apart, or family members, certain family members, with a lot of safety measures. And I don't, at least for me, it's felt very, very powerful. I a couple of weeks ago went to see my mother-in-law, and I have 3 young children, and she hadn't seen them in months. And we just stood, very far apart. We were only with her for about 10 minutes. She's in the high risk group. I mean, she was, the smile didn't leave her face, right? And she, her eyes were filled with tears the whole time, tears of joy. And it lasted for days, and it was so little. She got to see them in person. She doesn't really call. Once we talked on Zoom. So this is part of that generational thing. So how meaningful are those connections when they're not in person? Even without being able to hug her, it still was more meaningful, I think. So we have that loss. And then another thing that I think I haven't heard a lot of people talking about, but is really the loss. There's so little separation between work and personal life. So many of us are working from home. And we have our whole family home, and a lot of times we have additional family now. So there just seems to be a loss between those boundaries. Not only that, but then the communication, the technology that we're using to communicate with our friends and family is often the same that we're using to work. Okay, so we've all heard of Zoom fatigue, and I've been working on Zoom all day, and now, I really don't want to get on Zoom to talk to, my mother or my brother or whoever else that I might be trying to connect to. And of course, overall, there is a lot of stress and anxiety, and this affects it. And what happens with this is that, and some of these lists that I have here, some are both, right? Some are fears, and some are actual loss. So, fear of the other, xenophobia, has increased incredibly. And it makes sense. And the other is just anyone at this point, because do they have the virus? Are they gonna pass the virus on to me? Contamination. Fear of death, fear of getting sick, of your family getting sick, fear of economic hardship. Like I said, some of these are not fears, they're actual losses, right? Many of us have gone through economic hardship, and all the other things that are listed here on the left. And then we've lost all these other things. We've lost a lot of celebration, we've lost rituals, the grief process. You know, when someone does pass away, most of us can't go to be with family when that happens. To have a ritualized way of grieving like we used to. Stability is certainly gone. Money for all of us, I believe, is at least reduced. And entertainment. Entertainment has become solely on screens. And for, you know, for even if you love watching television, you're probably sick of it at this point. You know, a lot of us had other ways of entertaining ourselves and having fun. And it's really hard to do it by yourself in front of a screen. And what I see as consequences of this, of all this fear and this loss, is that if we're not careful, and I don't know which one comes first, but if we're not careful, we will lose patience, we will lose compassion, we will lose empathy, and we will lose trust. And I think we have lost all of those things to a certain extent, and I would imagine that all of us are working on a daily basis, on an hourly basis, to try to balance it out and try to reflect on, okay, that wasn't a good moment. How can I be more patient the next time my child asks me for the same thing 5 times, or the next time that the Zoom link doesn't work? And the reason to be careful with this and to really stay focused on not losing those things is because we're in this mode of hypervigilance. We kind of go back to the primal state of our minds, which we're looking for the enemy all over, right? We're looking for the lion or the tiger or whatever animal might eat us, or another person that might be trying to kill us. And it leads to breakdown in communication. We end up with that flight, fright, or fight mode in our brains, and we can't think as well. We can't stop and reflect. It's much harder to feel compassion and these other things listed when we're in that state. And then, yes, we have less than ideal social interactions, as an understatement of that. And so that's kind of what I saw as us going into this as the overall impact of what we're going through. In terms of our field now, focusing on what I see with what's going on in our field, one thing that I noticed almost immediately was that there's been an increase in news stories about interpreters and about patients and other individuals who need interpreters, who work with interpreters to be able to communicate. There's just been a large number of stories, and I was interviewed for some of them, and then they just started to really, that's how I started noticing them. And then it was like all of my colleagues were being interviewed, and actually some of them quite good, quite nuanced, getting to the heart of the matter. Not only about spoken language interpreters, but also a lot of news about the ASL interpreters. And, which is like, wow, you never noticed them before. But, I think because it's a visual language, a lot of stories, a lot of profiles, right, of the unsung heroes who are the ASL interpreters. And we saw some of that for spoken language as well. But it does tend to be less. So these are just some of the headlines of the stories that were done in very big publications. Some of them were at a more local level, and then we did see Time Magazine, the New York Times, Forbes. There were, many of the big national publications did stories on this. And not all of them used that metaphor lost in translation. So let's talk now about what facilities are doing. This is based on, I talked to managers of facilities in a couple of different places. I was trying to get a broader view of the whole country, but I will admit that it is mostly focused on New England, which is where I live and work. and where I have the most contacts because it is my home place, so to speak. But I did hear from a facility in Ohio as well, and I also spoke to Language Line, one of the biggest, if not, it might still be the biggest provider of remote interpreting in our field in general. And they also gave me a little bit of information about what they've seen. And so it's kind of based on that. Some of you might be familiar with a live podcast that I did on Facebook on my page for Seven Sisters. If you haven't seen it, I encourage you to go to that. So it's Seven Sisters Learn, and this is on the last slide. And you can watch the live podcast episode that I did with several medical interpreters from New England, and then we had an interpreter from Ohio, from Cincinnati's Children's Hospital, who joined us to talk about what they're doing and what life has been like for them, and what their facilities have done. And then several of them here from Massachusetts as well. So thank you again. I know some of you are watching, so thank you again for your contribution to that. It's open and accessible for anyone to watch. And more are coming, more live ones and more recorded audios too as the podcast. What the facilities are doing, there's different things. Some of them are using remote staff interpreters. Now, what this means is that their own staff interpreters are now remote. Sometimes, in some cases, they were already remote, so they were working OPI, right, over the phone interpreting, or VRI, video remote interpreting, for their facility as employees. So they had a hub or a call center, whatever you want to call it, somewhere where they all went and worked remotely because the patients and the providers were not with them. Physically. And those people, in that case, a lot of them then moved home, but they were already set up to do it. They had the technology, they had the video phones, and it was a pretty easy transition to move from working remotely in a call center for their facility or for their company to moving home and doing pretty much the same thing. Although now, with the added difficulty that often patients were not together with the providers, so that all three parties are apart, right? No one is actually next to each other. And then other facilities that did not have a remote component with their staff also had their staff start interpreting from home, either over the phone and or video. So that was another thing. And then the next level would be remote contract interpreters, which of course, as we know, virtually every facility has some, well, I shouldn't say that. I actually don't know that. But many facilities do have some kind of contract with remote interpreting at this point, whether it's phone or video, and had to really ramp it up if they didn't. Those were the facilities, and this comes from reports out of New York, particularly, but I think there were problems in many other places as well, where they didn't really have a plan. They didn't really have a lot of language access in place, and they were really scrambling and really wondering, what can we do? You know, how are we going to reach our patients who need an interpreter? And so the reliance on remote contract interpreters, right, freelance interpreters or interpreters who are staff for a company, right, but the hospital isn't employing the interpreters, someone else is. That's really increased, of course. In person is still happening. The facilities still do have interpreters in person, and I think it's also slowly going back to more in person as we seem to hopefully be waning a little bit in this epidemic. But those interpreters, it's a lot less work. There's a lot less work for them, and it's under very different conditions than what they're used to as well. And then, of course, there's the scramble that virtually all facilities have had to do. Okay, and so it's really, it's kind of a mixture. For most of them, it's some kind of mix of all of these things. You know, we have remote that's staff, we have remote that's contract, we have some in person, or we're trying to figure out what to do in person, and we're scrambling, especially in March and April. But I think even in May, I think to this day, it continues to be something where a lot of facilities are trying to grapple with how to handle it, how to best deliver language access, how to best deliver care in a language other than English. And you know, I did try to get information from from other facilities, and they didn't want to give me any information. They didn't want to share anything, and I think it's I think it perhaps is out of wanting to protect, worrying that indeed, you know, they're not doing as well as they want to, and so they didn't want to go on the record to say, you know, what they're doing. In terms of what Language Line told me, they said that, and I don't have this in my notes, but so I'm gonna tell you what I remember, which is that the telehealth visits, they said, have doubled in time, because that was one thing that I was asking facilities. You know, have you seen an increase in the length of the phone calls or the video calls? And they said that with telehealth, yes, it's about doubled the length of time, and that there are, you know, more hospitals are relying on their, you know, Language Line's remote interpreters, perhaps because they don't have them in person, or they don't have enough. And also the other thing, actually, I do remember all of them. The other thing is that, of course, a lot of the visits to clinics that are not urgent in nature have reduced. So there's very little visits in clinics that aren't urgent, which is what I think what we would all expect. So now we've talked a little bit about what facilities are doing. Now we come to the really exciting part for probably most of the audience today, which is, what are the interpreters saying? What are the interpreters feeling? What's going on with them, with you? And, you know, how, you know, what is going on with this, with COVID and you? So you probably know that because if you're on this, you were on our mailing list, and you probably at least know that I conducted a survey. And within only a few days, I received 219 responses from across the country. Yes, there was a focus on New England because it was distributed at first through Paving the Way and Lisa Morris and other contacts that I have locally. But there were a lot of people from other parts of the country as well. And this this survey, so it was interpreters from around the country, really responding to a survey within a couple of days, which I was really, really grateful for. So thank you for participating. I'm going to keep up the work with this and keep examining this. I'm going to write something for the interpreter division of the American Translators Association. So I believe it's going to be a blog post, but as you know, an article kind of talking more in depth about this particular survey. So that's, you'll see that out there. And then probably more, I'll probably do more with it. I love doing this kind of thing. It's, you know, Lisa Colombo did mention my background in broadcast journalism, which I never got to practice very much, only a few years, and then I moved to translation, but it's something that I love doing. I love talking to people and doing research in that vein. As would be expected, 85% of the respondents were female. That's what we see in our field, right? It is mostly female. Most of them were over 40, so there was a couple different categories for age, and the vast majority did fit in the 40 to, you know, over 60. I mean, basically 40 plus. And the majority also had a lot of experience as a healthcare interpreter. So, you know, at least 11 years, which is quite a lot of experience. In terms of certification, it was also about half and half of certified and not certified. I believe. I might be misquoting. I don't have that written down. But if a large percentage of those respondents were certified, were nationally certified. Okay, so there were some decreases. There was a reduction in a lot of the questions that I asked. 81 of the respondents said that before COVID, so I asked the question, I'm going to set it up a little bit better, sorry, for the ASL interpreters. I asked the respondents about work. How much did you work before COVID and how much are you working now? How many hours a week? Okay, and 81 respondents said that before COVID, they worked between 20 and 39 hours, right? So kind of robust part-time up to full-time. And afterwards, it's only 41 people that said that. Okay, so that's a decrease in half. You know, half of the people that had been working 20 to 39 hours are not anymore. It's gone down. And then in terms of less than 20 hours a week, so people that were working less than part-time or less than 20 hours a week, that also reduced from 49 people to, or went up 49 people from there to 72 people. So we saw an increase in people that were working less hours. But there was like a beautiful, you know, it did a pie chart for me, and there was like this beautiful array of slices because I allowed people to say other. And so a lot of people said, you know, it's 5 hours a month. It's, you know, 2 hours a week. So, you know, people wanted to respond more than the categories that I had given them. So a lot of respondents were really not working very much at all as a healthcare interpreter. This was specific to healthcare interpreting work. A lot of them said that they weren't working any hours. Then I had a question of how much income have you lost? And this has been asked before of interpreters in general, but I didn't find anything that was specific to healthcare interpreters, but Interpret America and at least one other organization has done this survey of, you know, how much income have you lost? And 103 people, so again, 50% of the respondents said that they lost income that was related to healthcare interpreting. Okay, so 103 lost it, but over half, little over half, did not lose income related to healthcare interpreting. So here I'm just showing you some of the results that I got. This is from the ones I was just talking about. So, you know, when you look at income that was related and not related, there it's, you know, it's a more than half have lost it, and 40% have don't feel that they've lost income as a direct or indirect result of the pandemic. Of course, this is what they're answering and how they feel about it. And then we had one person that said they didn't know. This was another question that I asked, which is, what was the mode of delivery for your work? Okay, and they could check multiple answers. And so the majority of the respondents were working in person, but remember, this doesn't mean that they were not working also remotely. The question was, you could answer as many as you want, because I think that is the model nowadays. I think a lot of interpreters are working remotely as part of their job, even when they work in person. And then we have 86 people that were over the phone, 48 that were video. So of the respondents before the onset of the pandemic, we only had 48 people that were working as VRI. And then we had a couple of other one person responses. And then you see it really changes, right? When I asked about the current pandemic, what's the mode of delivery, it changed, right? So it went from 206 in person among my respondents to 98. So also a half, you know, a decrease of half of that. Over the phone, it went up to 137, and video remote, it went up to 124. So 124 people now say that they work as a video remote interpreter, whereas before it was only 48, again, of those people. And then I had a lot of answers for this too, that were, you know, one person added others in there. You know, so a lot of no work. We had a Zoom, which, yeah, Zoom, you know, Zoom could be considered video remote. And then they also have the RSI, right? The simultaneous add-on. And no work available. You can see a lot of these responses are about no work. Okay, now I'm starting to get to the more positive results, or the optimistic side of this. I asked interpreters about how they felt with their work, how satisfied they felt, and this is a really interesting spread. It's pretty. It looks pretty even. At first, it's between 15 and 23%. So we've got 5 categories, and the responses were divided somewhat equally among those. Looking in more detail, I'm not a statistician, but looking at in more detail, 1 and 2 are the lowest levels of satisfaction as a medical interpreter, and it amounts to 31, 32%. So a third of people are in the lowest categories of satisfaction. Whereas if you put together the 2 highest ones, then you get 44, 45%. So, a little bit trending a little bit higher. And then we have the 23% of the people that are kind of in the middle. So I was happy with this. I thought, this was not as much of a dissatisfaction that I thought I might see. And that's where it started to look really interesting. And that's where I'm going to focus now. The rest of my presentation, the rest of my talk about the interpreters is going to be focused on the open-ended questions that I posed to the respondents. So there were 2 of them. One was what are some of the challenges of working now as a medical interpreter during the pandemic, and they could just write whatever they wanted. I didn't give them preset answers. Okay, so it was open-ended. And what the next question was, what do you see anything positive out of this? Do you, is there anything that you think is a positive out of this, of working as a healthcare interpreter during this time? And the responses that I got were really beautiful to see. It was very moving to read it, to see in their words what interpreters were going through. And as you will see, a very interesting phenomenon whereby people who were giving me a lot of detail about real problems they were having in different different ways, different types of problems, were the same, at the same time, because in the response, this was completely anonymous. I don't know their names. I didn't collect emails or anything like that, but I do see, what each anonymous person answered in each question, so that I could do other types of analyses later on. And so I can see the person who said, one thing for challenges, I can see what they said about positive, and it's the same person. And it was really neat to see. So I'm going to share that with you now. So this is one respondent. So on the left, you're always going to see the challenges, and then on the right, you're going to see what they see as positive for them. What's going on that they feel is positive as a result of the pandemic and working in the field during that time, or not working for many of them, but being in the field. So this person talks about technology in both. So interpreting via phone and video are very challenging. Same person said, I've learned a lot about technology. This harks back to what I was talking about with the point of view of Viktor Frankl and Kessler, right? This is adversity. it's pain, it's difficulty. But then this person is able to say, well, but now I learned a lot about technology. So that's the positive. Now, there were certainly people who said nothing, I don't see anything positive, but it wasn't that big. I don't have the numbers for you, but if you have that, have that as a question, I can compile it. It takes longer, right? Because it's open-ended. But it was not a lot of people who said that. There was very little negative overall responses, which was really, like I said, heartwarming. Here we have, again, this is the same person, challenges on the left, positives on the right. The quality of the connection is impacted sometimes by the internet signal. The use of mask on the patient and provider end, right? So they're listing the challenges. And emotionally, it has been kind of heavy at the end of the day. So I didn't edit these comments. Unless there was a typo, I didn't edit the comments. Okay, so this person's listing 3 things that are difficult. Quality of the connection, right? We know that is a big issue. And tomorrow in the presentation that I'm going to give about remote interpreting, I'm going to address some of those things, the how-tos, what interpreters can do to have less difficulty interpreting, how they can make some improvements on their end so it's less tiring and less difficult. The use of a mask on the patient and the provider end, right? That's really tough for spoken languages because it's harder to hear, because it's muffled. And for ASL, it's difficult because the interpreter and or the patient, depending on who's being seen with the mask, a lot of the language is in the expression on the face, right? It contributes a lot to the visual language of the hands. And then the emotional side. This same person is noticing the positive. And I thought it was really beautiful to read. Providers are no more in a rush. Wow, providers aren't in a rush. That's big. That's really big to hear. They are listening more than usual. They are listening more than usual. That's wonderful. That's a wonderful thing for an interpreter and a patient to feel, that providers are listening more than usual. And then everyone is going the extra mile to help meet the needs of patients, right? Beautiful. And this is what the interpreters that I interviewed for that podcast said as well. There was such a strong sense of connection between the interpreter, the patients, and the providers. Again, we're all in this together, and it has become a cliche, and sometimes I get tired of hearing it on every commercial and when I'm waiting on the phone for something, but it's also very, very true. And it's a wonderful sentiment to have. And I'd rather have that sentiment than many other sentiments that are also out there. Here we have, again, challenges on the left, rewards or positives on the right, working in 2D, right? So screen working is 2-dimensional. Lack of tech-savvy patients or clinicians or interpreters causes slowdowns. Tech fuzzes sometimes. This is an ASL interpreter, I'm assuming, because they talk about the lack of access for deaf-blind patients. Squeezes some humanity out of the encounter. These are backed up by some studies too, which I'm going to talk about next. It still is far better to be able to use familiar interpreters instead of random phone or video interpreters. Okay, I'm also going to talk a little bit about that. I'm doing a time check here. This same person, I have come together with a couple of coworkers in empathetic support for one another. We call one another more now. We look to make sure we are on the same page to present to management so that we can build the strength of many voices. Another one, my team of 4 interpreters was furloughed. The weight of workload is overwhelming. Times are hard, so we rely heavily on phone interpreters from an agency. Another challenge for this person is remaining healthy and sane. Same person says, everyone I work with in the hospital has pulled together like never before. People are kinder and gentler. And the last one from the interpreters, from you who responded, is, and again, this is representing in general what was said. Were there responses that were different? Yes, but I'm not just picking 5 that were like this. I assure you. Learning about the struggle patients are going through is very sad and poses a challenge to understand how things got to this point. On the same person, patients and providers seem more grateful for our work. So it was very moving to do this survey, and like I said, I will do more with it, and then that'll all be public for everyone to be able to look at, send me comments, discuss it, you know, to see how it fits with what you're going through too. So now I'm going to move on to the section about patients. If you remember from the beginning, this is not based on work that I've done yet. I'd love to do, I really would love to do some work with patients. I think it's missing in our debates about the field. I think it's missing in our standards of practice to a certain extent. And I think we're afraid. We're afraid to know what the patients are feeling because I think there might be a lot more dissatisfaction than we think. But some researchers have been doing really interesting work. And I came across this webinar that is available on YouTube, publicly available on YouTube. It was recorded on May 20th. And these are the researchers that were involved. It was spearheaded primarily by Glenn Martinez from Ohio State University. They got a grant from PCORI, which is stands for Patient-Centered Outcomes Research Institute. They've put together 2 webinars. They put together a webinar in November, past November, for interpreters. And so all these links we will send to you through the mailing list of people who have attended today. And they've done really interesting research. And what's really interesting about their research, because it's funded by PCORI, is that the idea of this research is that patients are at the center of the research. If we're going to have patient-centered healthcare, then the research about healthcare should also be patient-centered. So this idea of involving patients in designing the surveys, in looking at what are the questions that patients should be asked, of looking at the data, helping to conduct the research, looking at the data afterwards, and writing up the analysis of the data that's found in this research, which is, I think, a really, really interesting and very much needed approach to research. Not only the inclusion of patients, but this type of inclusion. Okay, so it's not just patients as an animal in the zoo that we're going to observe and take notes and talk about, right? They are agents, they are their own person, and instead of doing research about them, let's do research with them. Yes, it makes it complicated that they, if we want to do language neutral or multi-language survey, which yes, we want to do it. We don't want to just do it with Spanish speakers. It makes it more complicated, but hey, we have a lot of translators and interpreters out there that can help with this type of research. So they did this wonderful webinar, and I'm going to focus on 2 researchers that I'm going to present to you here that were very gracious and sent me more materials other than what I saw in the webinar. And these screenshots are from that webinar, again, hosted by Ohio State University. Rachel Shostak has done research in Kansas, in Wichita, and I think also in Ohio. I think the research also comes from both states, as far as I understand. And she actually has done research with patients and their experiences with remote interpreting, and these are her conclusions, okay? They're not easy to read as an interpreter or as a provider, I would imagine. They think that remote interpreting, their experience with remote interpreting, by the way, is OPI and VRI, right? So phone and video interpreting, and a mix of agency interpreters, contract interpreters, perhaps some staff interpreters. That's not very clear. I don't think there's a lot of staff interpreters doing remote in Ohio or Kansas. And they worked a lot with Marty. Marty was actually involved in the research to a certain extent. But these patients were working with interpreters from all different agencies and companies. Limited conveying of emotions. Okay, these again are the conclusions of the focus group with the patients. Difficult for interpreter to explain what is being said in other conversations occurring in the room. So presumably it's a family talking, or perhaps some other medical providers that are talking, and so the interpreter, you know, couldn't negotiate that conversation flow. This is what patients are saying. Less negotiation of meaning between patient and interpreter. Okay, negotiation of meaning is one of these things that they talk about in communication studies, in applied linguistics, which is what this research is based on. Really interesting field to look at interpreting from, because it's applied to how people communicate. You know, how do we create meaning? And it's quite a sophisticated view for most medical interpreters. It's not something that we learn in our training as medical interpreters, but it's a very interesting way. And this, of course, this phrase here, less negotiation of meaning, comes from the researcher. The patients didn't use that. But what she's talking about here is there's less, in summary, there's less back and forth so that the meaning is conveyed beyond words. When we talk to anyone, we are usually negotiating when we're talking with someone, right? Right now, I'm talking at you. I don't see you responding to me. I don't hear you. You know, I don't know what you're getting out of what I'm saying. Hopefully you're getting most of what I'm saying. But when we're in a dialogue, we are actually creating meaning together. I say something, I see a response on you in the middle of my sentence, and I might change it. That's how conversation happens in a nutshell. There's a lot of other complexities too. And what the patients were feeling, and the researcher translated what they said into these words for applied linguists, is that there's less negotiation of that meaning. And it's not something that would violate our code of our standards of practice. But I can talk more about that at a later moment, or if you have questions afterwards, after today. And then also, you know, just the difficulty of hearing what remote interpreter is saying. So those are the conclusions, the main conclusions from her study. The other big thing was that the patients in this study all referred to the remote interpreter as la máquina. For those of you who don't know Spanish, it means the machine. So even though there was an interpreter behind the machine, behind the computer or the iPad or whatever device they used for video remote, they referred to them in the focus study, in the studies, la máquina, and talked specifically about how they were working with the máquina. So they weren't focused on the people, they weren't focused on the provider or the interpreter. It was focused on the fact that they were looking at a screen, okay, even though there was a person behind that screen. The other study that I'm going to very briefly touch on is the one that was done by Carol Hardin and Glenn Martinez, again from the same group with the same grant. And the big thing with this is that patients talked about getting interpreting was kind of like a lottery. They didn't know when they were going to get interpreters or not. It kind of felt like you were lucky if you got one. You didn't know who you were going to get. You didn't know how it was going to go. You didn't know when it was going to happen, when it was going to stop or drop out. And that they felt like they were being passed around like a ping pong ball. Okay, not something very easy to hear. But I think it's important that we listen to this and that we figure out a way to incorporate this knowledge into how we go forward. Very briefly, I'm going to summarize what I think has worked, and I've already touched on some of this. And it relates to the, you know, again, the facilities that I talk to, the interpreters that I talk to, and my own take on it. For facilities, if you have a language access plan, you're going to be much more prepared. You were much more prepared, and you dealt with this a lot better. if you had a solid language access plan, if it was something that you didn't really have or that you weren't paying any attention to, and therefore your staff really didn't know how to get in touch with an interpreter, with a trained or qualified interpreter, that's when things got really ugly. And I think that is what happened in New York, a report that came out about how awful the situation was in New York hospitals, because they hadn't been using a lot of interpreters to begin with, and they just were at a loss as to what to do. In terms of staff interpreters, it does seem that having staff interpreters, and this is based on talking primarily to Vanessa Costa, who's the Director of Interpreter Services and Multilingual Services, and she has a long title, at Cambridge Health Alliance, which is a large facility with a large healthcare system with many facilities here in Metro Boston. And she has a large group of staff interpreters that were working remotely in a hub and now are home. And it worked very well for them. And she's done surveys with the patients, and the patients talk about the same thing, that the continuity of having an interpreter that they know, so that when they talk to patients now, the patients were really happy when they saw interpreters that they knew from working with them face to face, right? They're not La Máquina, even though they are in La Máquina. So those same interpreters who had been either remotely or in person with patients at Cambridge Health Alliance are now remotely with them when they're home and speaking to their provider at home. And they felt a sense of connection because of that. So I think this idea of really thinking about staff interpreters and focusing more on having staff interpreters doing a combination of in-person and remote, so that more of your interpreting is coming from local interpreters who know the context, know how the local insurance works. They know the pharmacies, they know the local health problems in that particular population. These things all change across the country. Even the type of Spanish, for example, right, where it comes from, changes from state to state here in the United States. And so having that, I think, becomes really important and a really interesting thing to look at. That focusing on those staff interpreters, even if you are going to go remote, because remote does, to a very large extent, increase productivity and efficiency of use of your interpreters. You know, you can better use them because they're not spending the time walking back and forth between different units when you have a large facility. And really flexibility, adaptability, and agility, that's important for everyone, but I put that here on the slide for facilities. For interpreters, I really think that's what's important as we move forward to think about is the idea of, you know, unity, or this, sorry, what has worked. What has worked has been this idea of unity, of connection, of compassion, which we saw when I shared with you the results of the survey that I did, and I saw it in the interviews, and I see it regularly among interpreters that I talk to. So hold on to that. That is something that I think is really working right now, and that will continue to work and continue to serve us as we go forward. Interpreters who were able to pivot in the sense of we're able to adapt. We're able to say, I've always worked as a face-to-face interpreter. Now I'm going to pivot. I have to pivot and change to being a remote interpreter, or something else that's maybe somewhat part of the language or language access, or working with patients, or doing some other kind of work. The interpreters who can see that, I think things have worked out very well for them. Of course, it always depends on your context, and none of this is your fault. If you are one of the interpreters for which this has been a horrible situation in terms of work, I don't want you to feel that I'm in any way blaming you or saying that you could have done better. I hope that's not what it comes across as. But I think thinking about pivoting, thinking about adapting to this by being agile, right? The idea of a pivot, and I think it's from basketball, right? That you can turn really quickly and do something different, or nuanced within, slightly a different variety. Continuing education, right? What has been working is that there are so many wonderful webinars and live virtual events that are free or at a very reduced price. And that's really great. And so many certified interpreters are getting all their CEUs right now. And so many trainers and institutions are donating their time for this. And I think that's really great. I think that sense, again, of donating, of giving, when we give, we get back, and what we give, we get back. So let's give love, let's give the resources that we have, the goodness in us, and that's what we'll get in return. And mindfulness, I think, is always important, and I think in this time especially. So just knowing, mindfulness can have to do with knowing your limits, recognizing your limits, recognizing what is going on and what you're feeling, and that it's okay to feel that. Getting more rest, listening to your body telling you that it's tired, that you need to take a nap, that you need to work less, that you need to do X, Y, or Z to get rest, or to rest your brain and do something else, exercise, go for a walk. All these are the things that are going to rest your brain, preferably not in front of a screen. And then debriefing, talking to people, reflecting yourself or with others about what's going on. Okay, the next steps, this is going to be, I have 2 more slides with this, and then you probably can guess this. I think what we do now is that we find meaning. We redefine or refocus our purpose. Why are we here? Why are we doing this work? Why are we involved with language access? And why are we here to connect with others? Okay, because by connecting with everyone, then we will ensure better health outcomes whenever that's possible. I think that is how we can go forward in a positive way. One more concept that I really want to introduce, and I hope you take away from today, is the idea of using linguistically marginalized patients instead of limited English. In a very quick nutshell, this comes from Rachel Shostak's research. She says that she likes to talk about these patients as linguistically marginalized. And it's similar to the term slave versus enslaved person, because for someone who is in the United States and doesn't speak English or doesn't speak it as well as a native speaker, that's not part of their identity. And by calling them LEP, limited English, you're putting a label on them, much like you're putting a label on someone as a slave that they don't identify with and that they don't want and that they had no choice over. Whereas enslaved person implies somebody's doing it to them. Somebody is enslaving these people. Linguistically marginalized gets to this idea that it's the context, that in this context where English is the strongest language, these patients are marginalized from that. So I think that's a really interesting concept. I think we do need to think a little bit, and I know I've gone 2 minutes over here. We do need to think about the standards of practice. I think it's time. They're very, very good. The National Council for Interpreting in Healthcare has really strong standards that have done great work for us so far. And I think we need to just start thinking about either themselves or how we talk about them, how we train our interpreters, how we educate the future interpreters in healthcare, and seeing if we can incorporate some of these ideas from the patients. And yeah, focus on meaning. So let's stay connected, stay united, learn to pivot, and don't lose hope. Viktor Frankl he has really good quotes from his book, which is, someone who has a why to live can bear almost any how. So just remember that. Finally, these are ways that you can connect with me and with Seven Sisters, my training company. And there's my email, Facebook page, again, where that live podcast is. And the name of the podcast, which is now available, there's 1 episode and there's another one dropping very soon. The name of the podcast is called Not Quite Magic. So thank you so much. And I have not been listening to you, so hopefully no one's been telling me to get off the stage.
Well,
Thank
I
you very
sent you a
much for
little
having me.
message, but that's okay. So folks, thank you for your attendance. And I just sent a code on the chat for all of the CEU recipients for NBCMI. So all of the CMIs out there, it's PTW 20-01 for your records. And thank you, Elena. It was a fabulous session as far as I'm concerned. I'm sure others will agree. I can see lots of thank yous in the chat. And I don't know if there are any questions, but if you do have questions, you can always send myself an email and I will get it to Elena or send it directly to Elena. And we will follow up with any links and information that she presented that she's willing to share with all of you. Oops, I see one question. Hold on, two questions. Could you please provide email or a copy of your PowerPoint, Elena? Is that something you're going to share with us to put on the website or?
Yeah, for sure. And I'm recording it on my end, like with my voice and my image. And so I'm going to put that out publicly too. And we might as well put it on the Paving the Way site and send it in an email. Yep. And my email address is here too.
Okay. We will be placing the PowerPoints that have been authorized by the speakers on our website, which is www.massmedicalinterpreting.org. And we have a special location where we'll be placing them, but do please give us a week or two to get those on our site. Let me see if there are any more questions quickly. And what was your last quote?
Oh, it was the one from Viktor Frankl was he who let me check my notes. It was he, but I said someone or anyone because it's not, he wrote
someone
the book
who has
quite
a
a while ago.
Mm-hmm.
He or she who has a why to live can bear almost any how, right? So if you have a reason to live, then you can bear almost any living conditions, I think is the idea with that.
Patricia Stewart, do you have a question? No. Okay. I guess not. All right then, folks. Thank you very much. If you have any glitches throughout the day, feel free to email or send us a message and we will help you out ASAP. I am monitoring my email all day. I've been fielding answers to many things, so we'll work with you. All of the other meetings for the rest of the day will be Zoom meetings rather than webinars, so it will look a little bit different and feel a little bit different. Thank you and have a pleasant day and a fantastic conference. And for RIDCUs, you do not have to do anything. We are taking your attendance and we'll be sending you the evaluations for everyone here. We will be sending you a SurveyMonkey evaluation to complete for both days. And that's essential that you send it in so that we can send you certificates and your continuing ed CEUs.
Yeah, thank you everyone. Sorry that I went over and that we didn't have time for more questions, but I'm willing to do as many get-togethers as people want. It was when we did it live on Facebook, we had a lot of people join us, and so one thing that I could do is to schedule it, and we'll send it out to everyone who attended, ahead of time, so that when to join us, and then you can certainly ask and comment and share your experiences, because that's what I want. It's not about me. It's really seeing what is it for all of us.
I would also like to thank our ASL interpreters that joined us today, as well as Lisa Colombo, John Wolfram, and all of our audience. We've had up to 200 and almost 60 at one point in time. It's a pleasure to have you. All right, we will be starting the next session at 11 o'clock. Thank you.